We will start with the upper limb lecture 1. Now, a few simple things at the beginning. Now, when it comes to the full skeleton, just to remind you, skeleton is divided into two components basically: the axial skeleton and the appendicular skeleton. So this is your axial skeleton and this is your appendicular skeleton. Now, when it comes to axial skeleton, the main parts of the axial skeleton are the skull here, vertebral column, sternum, and the ribs. These three components are the main parts. But other than that, remember, with the skull, middle ear ossicles are included, and with the sternum and the laryngeal skeleton and hyoid bone, which are central structures here, they are also included in the axial skeleton. Even though they are not the main components, for MCQ purposes and all, if it comes as components of the axial skeleton, it's not wrong. Then when it comes to the appendicular skeleton, you have the limb girdles. So in relation to the upper limb, you have the pectoral girdle or the shoulder girdle, and in relation to the lower limb, you have the pelvic girdle, and then the limb skeleton, upper limb and lower limb skeleton. So this is something very basic, but don't forget it. If you look at the muscles attached between the axial skeleton, which we just mentioned, and the pectoral girdle, when we say pectoral girdle, it's the clavicle and the scapula. If we look at the muscles attached between the axial skeleton and the parts of the pectoral girdle, you have the sternocleidomastoid here. Sternocleidomastoid here, attached between the base of the skull and the medial end of the clavicle. Then you have the subclavius attached between the clavicle and the first rib and the costal cartilage. Then you have other muscles like trapezius. Then attached to the vertebral border of the scapula, you have these three muscles: levator scapulae, rhomboids minor, and major muscles. Then on the anterior side to the vertebral border, serratus anterior muscle is attached. I have drawn it with dotted lines so that it's on the anterior side. Then you have the pectoralis minor attached between the coracoid process and the 3, 4, and 5 ribs. So serratus anterior, of course, between the vertebral border and the upper 8 ribs. Then if we take a look at the muscles attached between the axial skeleton and the humerus directly, you have the latissimus dorsi muscle and the pectoralis major muscle attached to the proximal end of the humerus. Then there are muscles attached between the pectoral girdle and the humerus. So you have a long head of biceps attached to the supraglenoid tubercle here. Then you have the trapezius, long head of trapezius attached to the infraglenoid tubercle. Then you have teres minor and teres major muscles. Then you have infraspinatus, you have supraspinatus. Then on the anterior side, you have subscapularis attached to the subscapular fossa of the scapula. Then covering all these attachments to the proximal end of the humerus, you have the deltoid muscle, which is anterior, posterior, and middle fibers. So if you take a look at anteriorly and posteriorly on the proximal at the proximal end of the humerus, this is how you see the attachment of some of these muscles. Now this is your greater tubercle. You can see it clearly in both views, anterior view and posterior view. So to the three facets, one superiorly and the other two posteriorly, there are three facets on the greater tubercle of the humerus. The supraspinatus, infraspinatus, and teres minor muscles are attached. Then you can see the supraspinatus attachment in the anterior view as well here. Then to the lesser tubercle, which is seen only in the anterior view, you can see the subscapularis muscle attached. Okay, then when it comes to the intertubercular groove here, or bicipital groove, with its lateral and medial lips. So this is lateral lip, and here it's medial lip. Lateral lip, pectoralis major is attached. Medial lip, teres major is attached, and to the flow of the bicipital groove, latissimus dorsi muscle is attached. Then you also know that through this intertubercular groove or bicipital groove, the long head of the tendon of the long head of biceps will pass to get attached at the top to the supraglenoid tubercle here, and the long head of triceps here coming like this and getting attached to the infraglenoid tubercle of the scapula here. Then a few things about innervation of some of these muscles that I mentioned here. There is a nerve called, there are three nerves actually, called subscapular nerves. I'll come back to this when I do the posterior chord of the brachial plexus. So you have upper subscapular and lower subscapular nerves supplying subscapularis and teres major muscles respectively, upper subscapular and lower subscapular. And the nerve carries C5 and C6, C5 mainly, C6 also there. Then you have suprascapular nerve. Suprascapular nerve supplies the supraspinatus and infraspinatus muscles with the same segments. Then the important, axillary nerve, which supplies the deltoid, which is an important supply, and then the teres minor muscle with the same types of segments, C5 and C6. Then about this condition called dropped shoulder due to paralysis of trapezius. Trapezius is a very strong muscle. It is important to keep the shoulders up, pull the shoulders up because of its attachment to the upper part of the spine. It will pull the shoulders upwards and keep it in position. So when trapezius is paralyzed on one side, very likely due to the damage to the spinal root of the accessory nerve, you get dropped shoulder on that side. Okay, you get dropped shoulder on that side. You can see here on the right side of this person, the shoulder is dropped compared to the left side. So this is due to the damage to the spinal root of accessory nerve, because the spinal root of accessory nerve supplies the trapezius and the sternocleidomastoid muscles in the neck. Then the wing scapula, when the serratus anterior muscle is paralyzed, likely due to damage to the long thoracic nerve, you get winged scapula, as you can see here, winging of the scapula here, because this muscle is paralyzed now. Okay, remember this point also. Few things about attachments on the clavicle. If you are given clavicle in the exam, and if you asked to describe it, or if you ask the structures attached to it at different places, you better remember this. First, you have to orient the bone correctly. Then you identify the superior view and the inferior view. The superior view is relatively smooth compared to the inferior view, which is rough because of the attachment of many structures. Now, to the superior surface, medially, sternocleidomastoid is attached. Then there is interclavicular ligament attached between the two, medial ends of the clavicles. Then to the medial 2/3 of the anterior surface, you get the pectoralis major muscle attached. Then to the lateral 1/3 on the anterior surface, the deltoid muscle, the anterior fibers of deltoid is attached. Then to the lateral end of the posterior surface, trapezius is attached. Then between the sternocleidomastoid and the trapezius, enclosing the two muscles, there is investing layer of deep cervical fascia of the neck, which not only encloses the two muscles, its attachment continues from one muscle to the other muscle along the superior surface of the clavicle. Then to the inferior surface, subclavius muscle is attached here. You can see it here. Then to the medial end of the inferior surface, costoclavicular ligament is attached. The ligament is between the first costal cartilage and the medial end of the clavicle. Then you have this important ligament which is called coracoclavicular ligament, which has got two parts. There is this trapezoid part and the conoid part. We call it trapezoid ligament and conoid ligament. So this strong ligament, you know, it's stronger than the bone itself. The middle third of the bone is weak compared to the ligament. So we'll talk about it when we discuss the fractures. So remember some of these structures. It's easy to handle if you know these structures, especially when it comes to vivas. Then surrounding the subclavius, there is clavipectoral fascia. Now it is said that the clavipectoral fascia surrounds or encloses the subclavius muscle and continues as the periosteum of the bone surrounding the bone. Few things about the fractures of the clavicle. You know, it is the most commonly fractured bone in the body, either due to fall on the outstretched hand or fall on the shoulder itself. It can get fractured. It commonly breaks at the middle third. Commonly, if you divide it into three parts, the middle third is the most vulnerable third for fractures. Then usually fracture line passes medial to the coracoclavicular ligament than lateral. Of course, you know, it can happen lateral to it, but most common site is medial to it in the middle one third of the clavicle. So this image shows you, you know, it's medial, fracture medial to the coracoclavicular ligament here. And once the clavicle fractures, because of the action of strong muscles attached to the upper end of the humerus and the clavicle itself, certain things happen. One thing is, if you look at the medial fragment, fractured fragment of the clavicle, it is pulled upwards by the action of the sternocleidomastoid muscle, this one. And the lateral fragment, even though the trapezius is attached to it and it can pull it upwards, when the person is in the upright position, the lateral fragment drops because of the weight of the limb. Now about this recording, I am recording this and I will share the link to the recording later. Okay, you need not record it separately. So the medial fragment is pulled upwards by the sternocleidomastoid and the lateral fragment drops down due to the weight of the limb. Then you have these strong adductors like pectoralis major and the latissimus dorsi and also, you know, teres major. They will pull the arm medially. Therefore, the two fractured fragments, they overlap here. There's overlapping of the two fractured fragments and shortening of the bone. So these are the anatomical, you know, reasons why, you know, this bone gets, you know, overlapped and shortened, and the medial fragment, you know, is pulled up and the lateral fragment is pulled down. Then the two joints on either side of the clavicle, you have two joints. Here you have acromioclavicular joint, and here you have sternoclavicular joints. So these two joints, there are a few important things about these two joints. Both joints are atypical synovial joints. Both these joints are atypical synovial joints, And in these atypical synovial joints, usually, you know, in synovial joints, the articular surfaces are covered with hyaline cartilage. But in these atypical synovial joints, the articular surface is covered by fibrocartilage. So that is one difference. Then the other thing is, both these joints, they have a disc, again, you know, formed by fibrocartilage. There's a fibrocartilage disc dividing the joint into two cavities. Okay, so both in these sternoclavicular and acromioclavicular joints, you see these features. Then the additional feature is in relation to the sternoclavicular joint. It is actually formed not only between the clavicle and the manubrium of the sternum. The costal cartilage is also involved in forming this joint. You can see this part of the costal cartilage. There is an articular surface there. So all three, this one, and this one. Okay, clavicle, manubrium of the sternum, and the first costal cartilage are involved in forming the sterno clavicular joint, atypical and atypical synovial joint. Then this concept of shoulder complex. So we talk about shoulder joint, but when it comes to the range of movements of the upper limb, it's much more than the movements allowed by the glenohumeral joint. So that's why this concept of the shoulder complex has come into discussion. So if you take shoulder complex, there are three bones contributing to form it: clavicle, scapula, and the humerus. Clavicle, scapula, and the humerus. So it's the bones forming the pectoral girdle, and then the first bone of the upper limb itself. Then there are four joints involved in forming this complex: the glenohumeral joint, the usual shoulder joint, then the two joints I mentioned, acromioclavicular joint and the sternoclavicular joints, the two atypical synovial joints on either side of the clavicle, and then this scapulothoracic joint. It's not a true joint, but it's a functional joint. It's a floating joint between the scapula and the rib cage, upper part of the rib cage. So when the scapula protracts, retracts, and when it rotates externally and internally, this joint is in action. Okay, so it's a functional joint, which is not a true joint. So this shoulder complex, therefore, it's considered a functional unit connecting the upper limb to the axial skeleton, and it's a combination of bones, joints, and also, you know, soft tissues. Okay, not only bones and joints, the muscles and ligaments are also, they play a part in that joint. So remember this concept. You know. Then rotator cuff muscles. So when you say rotator cuff muscles, we mention several muscles attached to the proximal end of the humerus and the pectoral girdle. So the rotator cuff muscles, they are attached between the scapula on one side and the proximal end of the humerus on the other side. They are all short muscles with flat tendons, and the tendons, they fuse with the capsule anteriorly, superiorly, and posteriorly, and strengthen the capsule. But there is no rotator cuff on the inferior aspect here, which weakens the capsule of the joint inferiorly, allowing it to the head of the humerus to dislocate inferiorly. And other important thing is, once it dislocates inferiorly, so you see the muscles, you have the supraspinatus here, you have infraspinatus here, you have teres minor and subscapularis. So these are the rotator cuff muscles. Then, okay, once it dislocates, the head, because of the pull of the muscles, head comes to lie in a position here in front of the glenoid fossa. So that you call it anterior dislocation. At the same time, this position of the head is called subcoracoid. Okay, because the coracoid process is here. So this position of the head is called subcoracoid position of the head, which you can see clearly in X-rays. plain X-rays. Then when it comes to stabilizing the shoulder joint, the most important stabilizing factor is the rotator cuff itself. Okay, so muscle factor is number one when it comes to the shoulder joint. Then you have the ligaments, and bones contributing to other bones contributing to stabilize it. Now, coracoacromial arch is actually a fibro-osseous arch. So you have two bones. You have the coracoid process here. You have the acromion of the scapula here, and you have the coracoacromial ligament here. So the three things, they form a coracoacromial arch, two bony points and the ligament, and which prevents superior dislocation of the head of the humerus. Then other than that, you have the coracohumeral ligament, which you can see here. Coracohumeral is this one, between the coracoid process and the head of the humerus. Then you have three glenohumeral ligaments, superior, middle, and inferior glenohumeral ligaments, which is not shown in this image, between the glenoid, the labrum and the head of the humerus. Then the fibrocartilaginous ring surrounding the glenoid fossa, deepening it to some extent, contributes to the stabilization of the shoulder to some extent, and this is called glenoid labrum. Okay, glenoid labrum. Again, you can't see it here, covered by these muscles. You know where it is. Then, in addition, long head of biceps and long head of triceps, they help in stabilizing the shoulder joint, because the biceps passes through the bicipital groove here and gets attached to the supraglenoid tubercle there, and the triceps does the same thing, getting attached to the infraglenoid tubercle. So they prevent upward and downward displacement of the head of the humerus, especially in the abducted position. Then when it comes to shoulder dislocation, you can see here this depression just below the clavicle, and the coracoid process is filled here in this person with the head of the humerus, because of this subcoracoid position of anterior dislocation. So that is one point. Then the other important point is, in 95% of the cases, it is anterior dislocation. Only less than 5% it's posterior dislocation. And okay, I mentioned this. And the other point is, because of the absence of the head here in the glenoid fossa, a deltoid and covering over it, you have this nice contour of the shoulder joint, rounded contour, that is lost on the affected side. So it's a very sharp angle here. It's not rounded like this. Okay. So that is another important thing. Then there are many nerves which are at risk during shoulder dislocation. You have musculocutaneous nerve here, radial nerve, you have scapular nerves, you have axillary nerve. All these nerves are at risk, but the most the axillary nerve has the highest risk. Okay, even though others are also at risk, don't say that it's only the axillary nerve. Even the others are at risk, but the axillary nerve is damaged more often than the others, because of its position very closely related to the surgical neck and binding around the back of the surgical neck. It can get damaged during shoulder dislocation. So in this dislocated shoulder, you can see two things. One thing, on the right side, it's dislocated on this side. You can see the rounded contour is lost on the right side, and you can directly feel the acromion process here. And you can actually see, and you can feel also, the head of the humerus here in this position, subcoracoid position. In the X-ray, you can see it clearly. In the lateral X-ray, it would be more clear that the head lies in front of the glenoid fossa. Then this painful arc, which is another clinically important condition. Painful arc actually happens in the middle. Now, if you take 180 degrees of shoulder abduction, 180 degrees of shoulder abduction, it is the middle 80 degrees, roughly, that causes maximum pain. when they abduct the shoulder. So the first 50 and last 50 out of 180 are relatively less painful. Okay, so it's the middle 80 degrees painful arc, and it can this type of pain can be caused by different conditions. You can be due to subacromial bursitis, supraspinatus tendinitis, or pericapsulitis, or which is called frozen shoulder, and it happens when the diseased parts impinge on the uh, acromion here. Okay, when they impinge on the acromion, okay, here, say this is subacromial bursa. So in subacromial bursitis, for instance, when you abduct below 50, above 50 degrees, like, you get this impingement here and causes pain. Um, Fractures of the humerus. It's not really humerus, okay. It's fractures of the humerus. Now, due to violent contraction of the supraspinatus, um, may be associated with shoulder dislocation also. When the muscle violently contracts, uh, the greater tubercle to which it is attached can be pulled off, which is called avulsion fracture. Okay, avulsion fracture of the greater tubercle or tuberosity. And the issue is when the avulsion fracture occurs, two things happen. One thing is the first 15 degrees of abduction is gone because for that abduction, supraspinatus is responsible, acting through the greater tubercle. So that first 15 degrees of abduction will be lost even when the axillary nerve, even when the suprascapular nerve supplying this muscle are intact. Even though it is intact, you can still get loss of first 15 degrees abduction. Then, other than that, now you also know the infraspinatus is attached to this one at the back, and the teres minor is also attached to the greater tubercle at the back, and they are lateral rotators of the arm. So because of that, the medial rotators of the arm will medially rotate it. Medial rotators like pec major, they will medially rotate the arm. Okay. Uh, then surgical neck fractures. Surgical neck can be fractured either due to falling on the outstretched hand, the usual, the way the fractures occur in the upper limb, or a direct blow. Then, due to surgical neck fractures, again the axillary nerve can get damaged. Together with that, posterior circumflex humeral artery also can get damaged uh, because they run together very close to the posterior surface of the surgical neck of the humerus. Since the axillary nerve supplies deltoid and teres minor muscles, they get paralyzed. So the abduction of the shoulder joint will be gone. Okay, there is no abduction the shoulder joint because of the deltoid actually. Okay, but the first 15 degrees is intact. First 15 degrees of abduction is intact because of the intact supraspinatus supplied by the suprascapular nerve. So above 15 degrees, abduction will be gone because of the paralysis of the deltoid muscle. Then even when it comes to flexion, extension, and rotation, uh, in all three of these movements, deltoid is involved because of its anterior, posterior, and middle fibers. So these movements could be weak, but there are other muscles that do it. It's not completely gone, but can be weak. Then, in axillary nerve damage, there will be anesthesia over the lower half of deltoid. Anesthesia over the lower half of deltoid, which is called that area. This anesthesia in that area is called regimental badge area anesthesia. So, regimental badge area is something like this. Now, the reason is if you divide the skin over the deltoid muscle into two halves, upper half here it is supplied by C4 dermatome, C4 dermatome, brought in by the supraclavicular nerves. It's supraclavicular nerves, supraclavicular, not suprascapular, supraclavicular nerves coming from the cervical plexus, bringing C4. C4 is outside brachial plexus. Okay, so it's above the brachial plexus. Then the skin over the lower half of the deltoid, this area is supplied by the um, it is called actually upper lateral cutaneous nerve of the arm, which is a branch of the axillary nerve. It is a branch of the axillary nerve. Uh, when the axillary nerve is damaged, you get sensory loss here in this lower half. Why you observe only sensory loss in the middle part of the lower half is that because of overlap of other nerves, they actually compensate for the anterior and posterior sides, but the middle part where the regimental batch is applied is completely under anesthesia. It's anesthetized because of the damage to the nerve. Anterior and posteriorly there is overlap with other nerves. Okay, that's the reason. And this, the dermatome here, lower half is C5, you know that. Okay, C5 brought in by the axillary nerve. Then shaft fractures, it can happen in the upper part, lower part, or in the middle. So if you concentrate on the midshaft humeral fractures, uh, the midshaft humeral fractures pass through the radial groove, and the structures in the radial groove can get damaged. So the radial nerve and the profunda brachii artery or deep artery of the arm can get damaged. Uh, so when the radial nerve is damaged in the radial groove, there will be wrist drop. There will be wrist drop in the patient. Okay, and there will be loss of extension and weak abduction of thumb. Now, why there is loss of extension of thumb is that both extensor pollicis longus and brevis, are supplied by the branches of the radial nerve. Therefore, thumb cannot be extended. So, when it comes to abduction of the thumb, the thumb, there are two abductors. The abductor pollicis brevis supplied by the median nerve and longus supplied by the branches of the radial nerve. So abduction could be weak. Then there's weak supination, because again there are two main supinators, supinator itself, which is the prime mover for supination, and the biceps, which is a very strong supinator in the half flexed elbow. So biceps is intact, but supinator is gone. Therefore, there can be weak supination when the radial nerve is damaged, because the supinator is supplied by branches of the radial nerve. Then there can be anesthesia over the back of the forearm and the dorsum of the hand. So this anesthesia over the dorsum of the hand could be limited to the skin over the first web. Okay, first web is here. Skin over the first web only can have anesthesia because of overlap in that other parts of the dorsum of the hand. Then supracondylar fractures. Again, the commonest reason is falling on the outstretched hand, especially when it comes to the extensor type. 95% of the time, it's extensor type where the distal fractured fragment is pushed and angulated backwards. Then, in about 5% of the cases, it is flexion type, and usually flexion type is due to falling on the elbow itself. Flexion type. The distal fragment is angulated and displaced anteriorly. And if you compare the two, flexion type is at a higher level of risk for neurovascular structures than the extension type. So the uncommon type is at a higher risk, especially higher risk of damaging the ulnar nerve because of its position behind the medial epicondyle here. So that's an important point. Then the other point is due to flexion or extension type, either type, you can get obstruction or damage to brachial artery, and that can cause compartment syndrome. That can cause compartment syndrome if the compartment syndrome affects both flexor and extensor muscles of the forearm equally, if they are affected equally, you get this typical type of Walkman's ischemic contracture. Sometimes, this same deformity that you can see here might not be there, because if there is asymmetrical fibrosis of flexors versus extensors, or extensors versus flexors, the deformity could be different. Okay, but if there is equal fibrosis both sides, then you see this typical Walkman ischemic contracture deformity, where the wrist is flexed here, and the metacarpophalangeal joints are extended and the interphalangeal joints are flexed. So what happens is the tension in the fibrosed flexor muscles will flex the wrist joint and the interphalangeal joints, and the tension in the extensor muscles due to fibrosis will extend the metacarpophalangeal joints. Okay, so you get full claw hand in Walkman ischemic contracture. And there's another small point. Now this image here, the relationship between the three bony points, the two epicondyles, medial and lateral epicondyle, and the olecranon of the ulna here. So this three bony point relationship is not disturbed in supracondylar fracture. Okay, it is not disturbed in supracondylar fracture. So it is disturbed in elbow dislocation. Okay, so this is how you differentiate between supracondylar fracture and elbow dislocation clinically. Without doing an X-ray, you can look for the three bony points. Then fractures of the distal end of the forearm bones. Distal end of the forearm bones. So Colles fracture, which will give rise to the Dinner fork deformity due to displacement and angulation of the distal fragment, posterior displacement and angulation of the distal fragment. So it can be either only radius or radius and ulnar. Both you know these things. You are working in hospitals now. The only thing is, even though it does not cause much problems with neurovascular structures, to my knowledge, there's a risk of damage. Okay, there's a risk of damage to the median nerve, radial, ulnar arteries, and the flexor pollicis longus tendon. Okay, this is what the book says. Okay, but I don't know how many cases you see in the clinical setup with this damaged. Whatever I have seen in my short experience in the hospitals, I haven't seen any case with neurovascular structure damage, but you might see, those who are in orthopedic units and all, you might see. So this is one thing, and it's common in both males and females over 50 years due to osteoporotic changes. Colles fractures is high in that age group, and then you have reverse Colles. So Colles fractures usually falling on the outstretched hand, palm hitting the ground, or the anterior aspect or the palm, the volar aspect hitting the ground. But Smith's fracture is the opposite. You can see it here. Smith's fracture is you fall on the back of the hand, the dorsum of the hand. So you get the distal fragment driven anteriorly, causing it's not dinner fork, it's garden spade deformity. It's like a garden spade. Okay. And again, when it comes to Smith's fracture, just like this flexion type and extension type supracondylar fractures, I said flexion type is less common, but it has a higher risk for neurovascular structures. Here also, Smith's fractures has a higher risk for neurovascular structures damage. Okay, it is also called reverse Colles. You know that, yeah. So you see here the dinner fork deformity in Colles fracture and reverse Colles, garden spade deformity. Okay, so it's like a garden spade. Then a few things about scaphoid fractures. Now, the important thing about scaphoid fractures is that if you don't specifically look for it um, in another upper limb fracture, you might miss it. Okay, so if you miss it, depending on the fracture type, the patient can end up with avascular necrosis because of the peculiar blood supply to the scaphoid bone. That is the basic point. So you should look for scaphoid tenderness in the anatomical snuff box in any patient with upper limb fractures or with a history of falling on the outstretched hand, because the scaphoid can be fractured without notice. It can go unnoticed. So remember this point. So you press the anatomical snuff box, the flow of the anatomical snuff box, and this bone scaphoid contributes to form the flow of the anatomical snuff box. So the patient will be having pain when you press. There is severe tenderness when there is scaphoid fracture. And why it undergoes avascular necrosis is that its blood supply comes from the distal side. Okay, blood supply comes from the distal side. So it can fracture. If you divide the bone into three fragments, it can fracture in the middle fragment, middle third, anterior, the proximal third or distal third. But the proximal third fractures, proximal end fractures have the highest risk of avascular necrosis. Okay, so the distal uh, fractures has the lowest chance of avascular necrosis. This is the reason. Say you take three types of fractures. You can see when we say distal, it's not always coming from the most distal end. Some arteries can enter it, little proximal to the most distal end. Therefore, say a fracture here in that area might not cause avascular necrosis because of some of these, proximally placed blood vessels. But if the fracture is somewhere here, as you can see here, definitely you will get avascular necrosis because there are no blood vessels entering from that end. Okay, so that is the reason for highest risk in the proximal end. Then few things about superficial veins. Few things about superficial veins. This is not very important also because you know these basic things, but I will just rush through it. So you have the two main veins in the upper limb. The superficial veins are the cephalic vein and the basilic vein. So that is number one. Cephalic vein starts from the lateral side or the radial side of the dorsal venous arch here, and the basilic vein starts from the ulnar side of the dorsal venous arch. Cephalic vein runs along the lateral aspect, you call it preaxial border of the upper limb, all the way, and it enters the delta pectoral groove here. You have the delta pectoral groove here between the deltoid and pectoralis major. It pierces clavipectoral fascia just proximal to the clavicle, and it enters the axillary vein. Enters the axillary vein, and the axillary vein becomes subclavian vein at the outer border of the first rib. That's how it goes. But on the other hand, the basilic vein, it pierces deep fascia in the lower part of the arm, goes in, and it joins brachial vena committantus. These are brachial vena committantus, and it forms the axillary vein. And usually this happens in the lower border of teres major muscle. Okay, lower border of teres major muscle, and that axillary vein runs through the axilla, and it receives the axillary, the cephalic vein, as I said before, just distal to the outer border of the first rib, forms it actually becomes the subclavian vein proximal to the outer border of first rib. And the other important thing is, now these are superficial veins, basilic and cephalic are superficial veins. Then you have a deep set of veins which are called vena committantus. Okay, it's a venae committantus. NE should be here, venae committantus. So you have venae committantus in relation to the brachial artery here in the arm, and in the forearm in relation to the ulnar artery and radial artery. You have vena committantus, which are usually two in number. Okay. In each artery, you have two vena committantus roughly. Okay. So, and the vena committantus, they follow the arteries as I mentioned before. So you have ulnar vena committantus, radial vena committantus, and brachial vena committantus. And when it comes to perforating veins, compared to the lower limb, even though there are several perforating veins in the upper limb, compared to the lower limb, there are few in number. And there is one important perforator in the upper limb, which is called deep median vein, or it is sometimes called median cubital perforator. Now, why it is important? This perforator connects the median cubital vein to the brachial vena committantus at the cubital fossa here. Okay, median cubital vein, which is superficial vein to the brachial vena computatus, which are deep. So this deep median vein, it pierces the deep fascia or the roof of the cubital fossa to do that. Now the important point is that because of this perforator, now this median cubital vein, it's anchored because of this perforator. It's anchored in that place. So you know that the median cubital vein, it has a very constant position in relation to the roof of the cubital fossa here. Not only that the position is constant, it's fixed or it's anchored because of this perforator. Therefore, you know, when you prick the vein, it doesn't move very much. Okay, so that's why we select that site for veiny punctures very often. Okay. Uh, and remember, you know, all these veins in the upper limb also, just like in the lower limb, they have valves. Okay. They have valves directed towards the heart. Then a few things about cutaneous nerves, not all cutaneous nerves, the important ones. So I already mentioned about this upper lateral cutaneous nerve of the arm. This is the cutaneous or the sensory component of the axillary nerve. Okay, we talked about axillary nerve a lot today. In several places we talked about it, difficult to draw here. Okay, so this is a branch of the axillary nerve. So this is the one that supplies the skin over the lower half of the deltoid with C5. Okay, so it's C5 dermatome, and because of this, when the axillary nerve is damaged, you can get sensory loss over the lower half of the deltoid, especially in the middle part, which is called regimental patch area, because the anterior and posteriorly there are overlaps, you know, from other nerves. Okay, so these are actually your supraclavicular nerves coming from cervical plexus. Then on the medial side, the skin of the axilla is supplied by intercostobrachial nerve. Intercostobrachial nerve. So this nerve brings T2. T2. So T2 means it's outside. This is here above the upper half of the deltoid. It's C4. Sorry, it's C4. C4 outside brachial plexus, and here in the axilla also it's T2 again outside brachial plexus. So this intercostobrachial nerve, say if this is your, you know, thorax, and this is your, you know, axilla here. So this is your upper limb. So your mandibular-sternal junction, sternal angle is somewhere here. So T2 is actually supplying below the mandibular-sternal junction. Okay, and that strip, dermatomes are like that in the chest. That strip continues here into the axilla. Okay, so it's actually an intercostal nerve uh, entering the axilla and supplying it. That's why it's called intercostobrachial nerve. Okay, so that's interesting actually. Then you have lateral cutaneous nerve of the forearm. Lateral cutaneous nerve of the forearm is another important cutaneous nerve because just like, this upper lateral cutaneous nerve of the arm, which is the cutaneous component of the axillary nerve, lateral cutaneous nerve of the forearm is the cutaneous component of the musculocutaneous nerve. Okay, musculocutaneous nerve, which is the nerve of the anterior compartment of the arm. Okay, musculocutaneous nerve. So the what happens is the musculocutaneous nerve again has two parts, muscular part and cutaneous part. The muscular part is given to the muscles in the anterior compartment of the arm, the biceps brachialis and coracobrachialis muscles. And then the cutaneous component actually emerges just lateral to the biceps tendon here at the cubital fossa as the cutaneous component, which is the lateral cutaneous nerve of the forearm. Then then you have superficial branch of the radial nerve. So that's a different thing. Don't get confused between the lateral cutaneous nerve of the forearm and the superficial branch of the radial nerve. Radial nerve, I'll show you the nerves towards the end of the lecture. Radial nerve at the elbow, it divides into its two branches, the deep branch and the superficial branch. Okay. So deep branch is the muscular branch. Okay. So, and the superficial branch is the cutaneous branch. So superficial branch of the radial nerve, it supplies the medial aspect of the dorsum of the hand. Lateral aspect of the dorsum of the hand. Medial aspect is the dorsum of the hand is supplied by you can see here, posterior cutaneous branch of the ulnar nerve. It supplies the lateral 1.5 fingers. Then the medial half is supplied by the medial 2/3 is supplied by the radial nerve. But the only issue is that this superficial branch of the radial nerve, even though it supplies the lateral almost 3.5 fingers, if you damage the nerve, sensory loss could be only limited to a small area at the first web because of overlap by other nerves. Ulnar overlaps here, then median nerve overlaps from that side. Therefore, actual sensory loss could be limited to the skin over the first web. Okay, skin over the first web is somewhere here. Okay, somewhere here. Then what are the other important nerves? Okay, so posterior cutaneous branch of the ulnar nerve, I just mentioned it. It supplies the medial end of the dorsum of the hand, plus anterior side is supplied by the main nerve itself. Then the other important one is palmar cutaneous branch of the median nerve, another very important cutaneous branch. So this palmar cutaneous branch of the median, you know that it doesn't pass through the carpal tunnel. Therefore, it's not affected in carpal tunnel syndrome. So there is no anesthesia over the thenar eminence. Okay, so the skin over the thenar eminence is intact in carpal tunnel syndrome because of palmar cutaneous branch of the median nerve. So the reason why I mentioned these cutaneous nerves is that it's important to remember them by name and the basis why you remember them, the reason why you remember them. There's always a reason why you remember these nerves. Then this point I mentioned in a previous slide about the dermatomes. So if you look at the chest, so this is sternal angle of Lewis, sternal angle here, and below this it's T2, intercostal nerve. So it's intercostal brachial because it supplies the uh, skin of the axilla. So then say I have mentioned here, recall when you are looking for sensory level, if you are looking for a sensory level in a neurological examination, you start from the lower limbs and go upwards looking for sensory level. Always when you come up to the sternal angle, you don't go, you don't jump into the blue area. Okay, you always go into the upper limb and follow uh, the the dermatome. So after T2, it's T1. Okay, T1, then C8. This is all in the upper limb because of the brachial plexus. Then you come back into the neck area like this. Okay, so usually it's T2 here, and here it could be C4 or C3, depending on different people. C4 or C3. Okay, so it's easy to take as C4 because C5 to C6 it's brachial plexus. So, C5 to T8 is brachial plexus. So you can have T2 here and C4 there, outside brachial plexus. Okay. Then the other important thing is when it comes to the hands, you need to remember two things. One thing is the dermatomes. So the easy way out is to remember thumb C6, then the little finger C8, and the middle finger here is C7. Okay. And if you overlap this with the nerve supply, so the first one is dermatomal supply, then second one is nerve supply. So you can clearly see that C6 and C7 they are given by the median nerve. Okay, they are given by the median nerve here. Okay, and C8 is given by the ulnar nerve. Okay, here also on the dorsum, C8 is given by the ulnar nerve, and the C7 and C6 are in this case given by the radial nerve because it's the radial nerve that supplies the dorsum of the hand. Okay, so here it's median nerve, this part median nerve, this part ulnar, this part radial. Okay, this part again ulnar. Then I will go through the brachial plexus just just you can recall it. Okay, if I go through it, um, brachial plexus, the important things, um, it's from C5 to T1. These five spinal segments will give rise to the spinal nerves. Coming from these spinal segments will give rise to the brachial plexus. That is an important point for you to remember. So when you talk about the spinal nerves, you know that each spinal nerve divides into an large anterior primary ramus and a small posterior primary ramus. So roots of brachial plexus, when we say roots here, roots of brachial plexus are the anterior primary rami of spinal nerves. And the roots, they lie, if you take this area is actually the area between the scalene muscles, scalenus anterior and medius muscles. So roots lie in the neck between the scalene muscles. Then the upper two roots unite and form the upper trunk here. Then the middle root continues as the middle trunk. Then the lower two roots, C8 and T1, they unite and form the lower trunk. So you have three trunks, and usually the trunks are formed in the posterior triangle. That is, just lateral to the scalene muscles. So you have upper trunk, middle trunk, and lower trunk. Then each trunk is divided into an anterior division and a posterior division. So you have an anterior division and a posterior division here. Anterior division, posterior division, anterior division, posterior division. So each trunk has an anterior division and posterior division. All posterior divisions, they unite and form the posterior cord here. Upper two anterior divisions, they unite and form the lateral cord, and the lower anterior division continues as the medial cord. Now these divisions, I said the trunks are in the posterior triangle, and just distal to that, divisions, they lie under the clavicle. Okay, so divisions are found under the clavicle. Then the cords, when we say lateral, medial, posterior, they are named based on their relationship to the artery here, which is the axillary artery. Okay, so your axillary artery is here. So the cord that is lateral to it is called lateral cord. Cord that is posterior to it is called posterior cord. Cord that is medial to it is called the medial cord. So cords lie in the axilla. Okay, they lie in the axilla in relation to the axillary artery. Now you can see several branches are given off here from the cords, and the branches are given off usually in relation to the third part of the axillary artery. Okay, so in relation to the third part of the axillary artery, brachial plexus branches are given from the cords. Okay, there are branches coming from the roots. There are branches coming from the trunks. So the most important branch coming from the roots is the from C5, 6, and 7. 5, 6, 7, you get the long thoracic nerve supplying the serratus anterior. So that's something you have to remember. Then from the upper trunk, you get the suprascapular nerve. Okay. There are, few other things like, nerve to subclavius, dorsal scapular nerve. They are not very important, I think. But these two you have to remember. Then when it comes to branches, okay, I'll come back to it. I'll finish the branches also here itself because, you've done it before. From the lateral cord, this cord, you have three branches. Okay. Then from the medial and posterior cords, you have 5 branches each. Okay. So it's 5 here, and this one also it's 5. Okay, it's 3, 3, 5, 5. Okay, 3, 5, 5. It's easy to remember the branches if you take a look at them carefully. It's easy. Now, for instance, if you take the lateral cord, if someone asks you the branches coming from the lateral cord, you have the lateral pectoral nerve. The first branch is actually the lateral pectoral nerve. Okay. Then you have the musculocutaneous nerve going into the anterior compartment of the arm. Then it is the lateral root of median nerve. Finish. 1, 2, 3. Then, for instance, if you take the posterior cord of brachial plexus, the branches, you have 3 subscapular nerves. 3 subscapular nerves. It's upper, middle, and lower. Okay. Upper, middle subscapular, and lower subscapular. So upper one supplies the subscapularis muscle. Lower one supplies the teres major muscle. Okay. And the middle one, it is no longer called middle subscapular. It is called thoracodorsal nerve. Thoracodorsal nerve, and it supplies the latissimus dorsi muscle. Okay. It supplies latissimus dorsi muscle. Okay. So these are 3 branches from the posterior cord. Then the important branch, the axillary nerve. Okay. It's a large branch. Then the remainder, it continues as the radial artery. So that makes it 5. That makes it 5. When it comes to the medial cord, the first branch is the medial pectoral nerve going into the pectoralis minor and major muscles. Then you have two named cutaneous nerves. You have medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm. So that makes it three branches. Then you have the medial root of median nerve, four branches, and it continues as the ulnar nerve. That is the fifth one. Okay, so it's easy to remember. 3, 5, 5. Okay. Okay, so I already mentioned about the roots of brachial plexus lying between the scalene muscles, trunks in the posterior triangle, divisions behind the clavicle, and cords in the axilla. And cords, they approach the first part of the artery, embrace the second part, and this is the important one, last one. The branches of the cords are given in relation to the third part of the axillary artery, which is important to remember. Okay, so brachial plexus injuries. Now, upper root injuries, C5 and C6 root injuries, usually due to fall on the shoulder and the head like this, where the two get separated out, or due to forceps delivery, forced delivery. When the head is pulled by the forceps or something, while the shoulders are still stuck inside the birth canal, you can get, the same, separation. Upper roots can get damaged. So it's C5 and C6 nerve roots. So all the muscles supplied by C5 and C6 that we, started with at the beginning of the lecture are paralyzed, like, your supraspinatus, infraspinatus, subscapularis, teres minor, and deltoid. All these muscles, main muscles of the shoulder, are paralyzed. So therefore, the clinical features are the deformity itself is called Vater's tip position. You know this. Deformity is called Vater's tip position. But if you go for separate joints, it's interesting. Now, due to paralysis of deltoid and other short muscles of the shoulder, biceps and brachialis, because they are supplied by C5 and C6. So you get now here, if you look at the shoulder joint, it is adducted. Okay, because abductor, the deltoid is gone, supraspinatus is gone. Okay, so therefore it is adducted by the action of adductors. Pec major, latissimus dorsi, they are still acting. Their segments are at a higher level, C7, C8, like. Okay, so they are supplied. Therefore, the shoulder is adducted, and the lateral rotators, like, posterior fibers of deltoid, then, infraspinatus, teres minor, they are all gone. Therefore, the arm is medially rotated. Okay, so, or internally rotated. Then at the elbow, now the biceps and brachial is gone. Triceps is intact because it's C7 and C8. C7 and C8 segments supply the triceps. Therefore, elbow is extended. Elbow is extended. Now, so this one, shoulder adducted, arm medially rotated, elbow extended. Now, the supinator itself and the biceps, they are given C6 for supination. For pronation, it is C7 and C8. Pronation, C7 and C8. This is for pronation. This is for supination. So pronators are intact. Therefore, the forearm is pronated. Forearm is pronated, and the fingers are slightly flexed, because this is, the extensors are more affected than flexors. I don't have a clear explanation for this flexion of fingers, but the fingers are flexed, because at the wrist, it's 6, 7, 6, 7, both sides. Maybe, this 6 is, more affected when it comes to the extensors for some reason. I don't know. So the fingers are flexed. So this is called Vater's tip position. So it's interesting to, describe, at each joint how it happens due to the C5 and C6 damage. Then the opposite of it, brachial plexus lower root injuries. So it's C7 and C8 root damage, and it is due to one common reason is breech delivery, especially when the shoulders are stuck. If the buttocks are pulled, you can get opposite direction traction. So you get this separation here. Okay. So same thing can happen in an adult while falling from a height. If he holds on to something on the way, same thing can happen. Okay, so you can get lower root injuries. So C8 and T1, they supply intrinsic muscles of the hand. Okay, so intrinsic muscles of the hand are paralyzed. Now, when it comes to intrinsic muscles, the most important intrinsic muscles are lumbricus and interossei, and their action. The lumbricus and interossei together, they flex interphalangeal joints and extend metacarpophalangeal joints here. And when they flex interphalangeal joints, they flex metacarpophalangeal joints and extend interphalangeal joints. Okay, when they extend interphalangeal joints, they oppose the action of long flexors. When they flex metacarpophalangeal joints, they oppose the action of long extensors of the forearm. Okay. When the interossei and lumbricus are paralyzed, these actions, their opposing action is gone. Therefore, unopposed action of long flexors of the forearm, they will flex the interphalangeal joints, and unopposed action of long extensors of the forearm, they will extend the metacarpophalangeal joints. So you get full claw hand. Okay, you get full claw hand. Even other muscles come into play. It's easiest way to explain it through lumbricus and interossei, I think. And due to the traction on the spinal cord, other than this full claw hand, you can get Horner syndrome due to damage to the sympathetic fibers in the sympathetic chain. Okay, sympathetic chain rather than the spinal cord, the sympathetic chain. Okay. Then few things about the axilla. Uh, axilla is a pyramidal shaped area with an apex and a floor and four walls. So you have an apex bounded medially by the outer border of the first rib and posteriorly by the superior border of the scapula and anteriorly by the posterior surface of the clavicle. So that is the apex. Then you have a medial wall formed by the serratus anterior here, then the upper ribs and intercostal structures in the intercostal spaces. Okay, there are intercostal muscles and membranes there. So that forms the medial wall, which is the longest, I think. And the anterior wall is also longer. It is formed by pectoralis major, pectoralis minor, clavipectoral fascia, and subclavius. Then the posterior wall here is formed by the subscapularis here. Then you have teres major and latissimus dorsi. Then the lateral wall, which is the narrowest, is limited to the convergence of these muscles at the intertubercular groove. So it's actually the intertubercular groove area of the humerus, which forms the very narrow lateral wall here, which you can see here. Okay. And the floor, of course, is deep fascia passing between the thoracic wall to the arm. Okay. So that is the flow. So you can go through this quietly. What structures form, which walls. Okay. Then few things about the axillary artery. Axillary artery, the extent of the axillary artery is from the outer border of the first rib to the lower border of the teres major. Okay. Now, if you ask theoretically, someone asks you the extent of the axillary vein, the opposite of this, again, you take it the same way from the lower border of teres major to the outer border of first rib, but it's more applicable to artery than the vein. Okay. So, outer border of first rib to the lower border of teres major, and the artery is in this stretch. The artery is divided into three parts by the presence of pectoralis minor muscle in front of it. So the part above the muscle or proximal to the muscle is called first part, past covered by the muscle is called second part, and the part below that is called the third part. So if someone asks the extent of the third part of the axillary artery, it is from the lower border of pec minor to the lower border of teres major, therefore. Okay. And it is interesting, from the first part you get one branch, from the second part two branches are given, and from the third part you can see them here. From the third part three branches are given. So Okay, first part is superior thoracic artery. Anyway, we don't talk about it very much. Second part, you have thoracoacromial trunk and lateral thoracic artery. So this is an important artery, especially in females, because it supplies the lateral aspect of the breast. Medial aspect is supplied by the internal mammary branches. Lateral aspect is supplied by the lateral thoracic artery. And the anterior group of axillary nodes, we will take a look at it shortly. They lie along the lateral thoracic artery. That is the other important thing. Okay, and they drain the breast. Then thoracoacromial trunk. It's a trunk. So it has several branches. It has deltoid. It has scapula and pectoral. I think there are four types of branches. I think this is also important when it comes to scapular anastomosis, and all. We'll talk about it later. Then from the third part, you have two circumflex arteries, anterior and posterior circumflex humeral arteries, and the subscapular artery. So these are also important when it comes to scapular anastomosis, especially this one. Okay. Um, okay. So when it comes to the scapular anastomosis, so take it very, clearly into your mind. Usually, it is between the first part of the subclavian artery and the third part of the axillary artery. So this is the main part of the scapular anastomosis, between the first part of the subclavian and the third part of the axillary artery. So from the first part of the subclavian, you get two arteries coming. From the first part, you have suprascapular artery. Okay. And you have transverse cervical artery that has a branch, a superficial branch and a deep branch. So the deep branch of the transverse cervical artery. Now this transverse cervical artery and suprascapular artery, they are branches of the thyrocervical trunk from the first part of the subclavian artery. You can see it there. Okay. So that's why the first part comes here. So you have suprascapular artery and transverse cervical artery from the first part of the subclavian artery comes out as branches of the thyrocervical trunk. Then from the transverse cervical artery, there is a deep branch. So that branch is related to the vertebral border of the scapula. And the suprascapular artery, it enters the supraspinatus fossa, passing through the suprascapular notch. And its branches can enter the infraspinatus fossa, and they can anastomose with the branches of the circumflex scapular artery, which is a branch from the subscapular artery. Branch from the subscapular artery from the third part of the axillary artery. Okay, circumflex scapula is a branch of the subscapular artery from the third part of the axillary artery. So that's why the third part is there. Okay, so this is the usual uh, scapular anastomosis when there is gradual obstruction to the proximal part of the axillary artery or the distal part of the subclavian artery. You can get this as an alternative way of blood supply to the upper limb. That's why it's important. You have learned this. Then the other important thing is, in some people, now this deep branch of the transverse cervical artery is not there. Okay. So this is how it happens. I'll show you. Okay. Okay. So this, if you take the subclavian artery, now from the first part, you get the vertebral artery, you have the internal thoracic artery and thyrocervical trunk. What is important for us is the thyrocervical trunk here. From that, I said they get the suprascapular artery and transverse cervical artery. From second part, there's costocervical trunk. From the third part, there may or may not be a dorsal scapular artery. Okay, there may or may not be a dorsal scapular artery. In some people, uh, they don't have dorsal scapular artery. They have the thyrocervical trunk there, and those people are the ones who are having this deep branch of the transverse cervical artery forming the scapular anastomosis. But other people, it's like this. Now you have the thyrocervical trunk, you have suprascapular artery, transverse cervical artery, and inferior thyroid artery, the first three branches. Then, so this is involved in the scapular anastomosis. There's no issue with that one. Then this transverse cervical artery, it has superficial branch and deep branch. Okay, so this one we said it is involved in the scapular anastomosis. Now, uh, this superficial branch, superficial cervical artery is a name. Some people, they call the transverse cervical artery directly, they call it superficial cervical artery. Okay, superficial cervical artery. So that is one confusion. Then the second one is in those people who have a dorsal scapular artery coming from the third part of the subclavian artery, okay, then they don't have a deep branch of the transverse cervical artery. Okay. Then what is involved in the scapular anastomosis is the dorsal scapular artery. What is involved in the scapular anastomosis is the dorsal scapular artery. So then in such people, this is the dorsal scapular artery. Okay. And that's why I have put third part within brackets here. Okay. So in some people, it is first part of the subclavian through suprascapular artery, and the third part of the subclavian through the dorsal scapular artery, if they have it actually, dorsal scapular artery, that is involved in the scapular anastomosis. Okay. In others who don't have dorsal scapular artery, so there is no branch from the third part of the subclavian artery in such people, they have transverse cervical artery giving the deep branch involved in the anastomosis. It's a very small point anyway, you are doing postgraduate, no, that's why I said that. Okay. Okay. So actually, this is from Richard Snell. Even Richard Snell here, it, 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 he says deep branch of superficial cervical artery, not transverse cervical. So he calls this here superficial cervical artery, but other authors they call it transverse cervical artery. Even I, in my lectures, I call it transverse cervical artery. So this is your thyrocervical trunk from the first part of the subclavian artery. This is first part of subclavian artery. Transverse cervical artery, thyrocervical trunk gives transverse cervical artery. This one, he calls it superficial cervical artery. So here, this one, superficial cervical artery in place of transverse cervical artery. So if you know that, it's fine, Nobody will question you this on the in the exam, but when you study, you get this confusion. Okay, which artery should I call it? Okay. Then there's an extension to the scapular anastomosis. Now the extension is around the acromion here. Now what happens is there are acromial branches from the suprascapular artery. The suprascapular is already component of the scapular anastomosis. There are acromial branches going towards the acromion from the suprascapular artery. Then there are acromial branches from the thoracoacromial trunk. You remember this from the second part of the axillary artery, you get thoracoacromial artery or thoracoacromial trunk. From that, you get acromial branches. So these are acromial branches from the thoracoacromial trunk. Okay. Then you get some acromial branches, these ones, from the posterior circumflex humeral artery from the third part of the axillary again. Okay. So from the third part, you get anterior and posterior circumflex humeral arteries and subscapular artery. For the these acromial branches of suprascapular artery, thoracoacromial trunk, and the posterior circumflex humeral artery, they form a small anastomosis around the acromion here. So that is actually part of scapular anastomosis. So if you are asked to describe scapular anastomosis, better to describe this part also together with the main part. Okay, then few things about axillary lymph nodes. Uh, So axillary lymph nodes, they drain the upper limb, breast and the thoracic wall and the upper part of the abdomen and the back. Okay, upper part of the abdomen and the back. You can see here above the waist, uh, this is above the umbilicus. Okay, this umbilicus is here. Above the umbilicus, the abdomen, superficial lymph drains into the axillary, anterior group of axillary nodes. Then above the waist, roughly iliac crest area, the lymph from the back drains into posterior group of axillary nodes, which is the subscapular group of axillary nodes. Okay, so that is also important. Okay, then there are 5 groups. Okay, there are 5 groups. So you have an lateral group. You have a lateral group in relation to the upper end of the humerus. You have an anterior or pectoral group. You have subscapular or posterior group. You have a central group and an apical group. Okay, altogether it makes 5. So this is a diagrammatic representation of the 5 groups. So you have anterior, posterior, central, apical, and apical and lateral, groups. So supraclavicular is not axillary, it's a neck lymph node group. Okay. Now, if you look at the vessels in relation to which these nodes are found, now anterior group or pectoral group, it's called pectoral group because it lies under the pectoralis minor muscle in relation to the pec minor. You have it, so you call it pectoral group, and the nodes lie along the lateral thoracic artery. Then the posterior group, since they are very close to the subscapularis muscle, they are called subscapular group also, and they lie along the subscapular artery. So the lateral group, it lies along the axillary vein. Okay, it lies along the axillary vein in the proximal end of the arm. So the apical one lies in relation to the apex of the axilla. So even though I have drawn it here, it should be high up somewhere here. Okay, behind the clavicle line. Okay. Uh, when it comes to lymph drainage of the upper limb, this is how you remember it. Ulnar side, this side, it's not drawn here. So if you take the upper limb like this, ulnar side of the hand and the forearm, they first drain into the supratrochlear group of nodes. Supratrochlear group of nodes. In the olden days, people used to, look for this node in syphilis, actually. Okay, so it's a long story. Okay. So ulnar side, the hand and forearm drain along the basilic vein to the supratrochlear nodes first. Okay, then from there, it can go into the lateral group of axillary nodes and central, and then, it goes along. Then from the radial side, from this side, okay, lymph will drain along the cephalic vein, to the lateral group, some of the lymph to the lateral group, and some lymph will drain along the cephalic vein to the infraclavicular. Now, before the apical group outside, you get here, just below the clavicle, you get here infraclavicular group of nodes. So it can go into the infraclavicular group of nodes, which are not axillary nodes. From infraclavicular, the lymphatics can pass into the apical group, which is a deep group, which is the axillary. Apical is axillary. So initially, lateral part of the arm, the forearm and hand and arm can go into the infraclavicular group, which is not axillary nodes. From infraclavicular, lymphatics can enter the apical group of axillary nodes, passing through the clavipectoral fascia. You remember this, structures passing through clavipectoral fascia. So other than the veins and nerves, you mentioned lymphatics. So these are the lymphatics that connect the infraclavicular to apical, coming from the lateral aspect of the forearm and hand and arm. Okay. Then deep lymph from the hand, forearm, and arm, and whatever the lymph that has gone into the supratrochlear group, they drain into the lateral group. Okay, they all deep lymph drain into the lateral group first, then from there into the central group, apical, and goes into um, the thoracic duct on the left side and right lymphatic duct on the right side. Okay, few things about the compartments. This is a very straightforward, simple thing. You know this so many times, but I will just go through it. Now, the anterior compartment of the arm, there are three muscles: small coracobrachialis muscle, biceps brachii, and brachialis muscles. Now, the nerve is musculocutaneous nerve coming from the lateral cord of brachial plexus. The musculocutaneous nerve brings C5, 6, 7. I told you at the beginning, 7 usually goes into the coracobrachialis muscle. Okay, 5, 6 into the other two muscles. Then the other important thing is the posterior compartment of the arm is totally one muscle is there, the triceps, having three heads, lateral, medial, and long heads, supplied by radial nerve, C7 and C8 segments. C7 and C8 segments. Now, the anterior and posterior compartment are separated by two intermuscular septa, medial intermuscular septum and the lateral intermuscular septum. You know, this intermuscular septa, they continue as the periosteum of the bone. Okay, so they are very firmly attached to the bone, therefore. Other important thing is now at the lateral side, now this is the lateral intermuscular septum here. Okay, radial nerve can send some branches to that side. Now, if you divide this, it will be like this. you have the brachialis muscle here. So brachialis can get some supply. Brachialis can get some supply from the radial nerve. So it can have a dual supply. Remember this point, brachialis. It can be supplied by muscular cutaneous nerve largely and little bit on the lateral side in front of the intermuscular septum, lateral intermuscular septum, it can be supplied by the radial nerve as well. That's an important point at your level. Okay. Then the other important thing is musculocutaneous nerve. It is sandwiched between the biceps brachii and brachialis muscles. You can see it here. Then the other important thing is on the medial side of the arm, many of the neurovascular structures are found. You have the median nerve in front of the intermuscular septum. So your intermuscular septum is here. Okay, median nerve in front of it, ulnar nerve behind it. Now remember, ulnar nerve, it actually accompanies superior ulnar collateral arteries and veins. But the ulnar nerve, it is behind or posterior to the medial intermuscular septum in the lower part of the arm. In the upper part of the arm, it lies anterior to the medial intermuscular septum. And later it pierces the intermuscular septum together with superior ulnar collateral vessels and enter the posterior compartment. Okay. So it runs in both compartments. Remember that point. Okay, so this I already mentioned about brachialis getting dual nerve supply. Then okay, this is the second point I mentioned: ulnar nerve and superior ulnar collateral artery. Here they enter the posterior compartment somewhere here in this area. Okay, initially they are in the anterior compartment, then it enters the posterior compartment, goes behind the medial epicondyle, the ulnar nerve especially. Okay, so the superior ulnar collateral artery is an important artery when it comes to the elbow anastomosis. Okay, there are several collateral and recurrent arteries. Okay. Okay, so I will not talk about elbow anastomosis here. Maybe I will talk about it later in the next lecture. Few things about the four main nerves. This is from Richard Snell. It's a very nice diagram. I like it. Summarizes the four nerves very nicely. So musculocutaneous nerve, you can see here starting from C5, 6, 7. Okay. So it supplies coracobrachialis, biceps and brachialis muscles, and in the forearm, it becomes the lateral cutaneous nerve, the forearm. We talked about it, you remember? So this is about the musculocutaneous nerve. And you can see here that this one, lateral cutaneous nerve of the forearm, cutaneous part, it emerges piercing the roof of the cubital fossa lateral to the biceps tendon. Okay. Then it supplies the lateral aspect of the forearm. So that is the one I wanted to mention. Then the radial nerve, so it shows the 5 segments, C5 to T1. It enters the cubital fossa in front of the lateral epicondyle. No, before that, here you can see, okay, here triceps. Okay, this is an important thing. Okay, I have highlighted. So triceps, long head, gets a supply when the nerve is still in the axilla. So triceps long head is supplied when the nerve is still in the axilla, and the medial head is also supplied, quite, proximal to the radial groove. So if the nerve is damaged somewhere in the radial groove, okay, then triceps is not totally paralyzed. So that is the important thing. So that's why, when you damage the radial nerve in the radial groove in the midshaft fracture of the humerus, usually, you get wrist drop, but you don't get total, loss of extension of the elbow. It could be weak. It could be weak because the lateral head may be paralyzed. Even the medial head, part of it may be paralyzed, but part of the muscle is still active because of this high branches given in the axilla. Okay, so that is an important point to remember. Then, okay, so then the other point is that the nerve, it enters the forearm in front of the lateral epicondyle here of the humerus, and it divides into 2 branches, deep branch and superficial branch. So superficial branch is the one that supplies the dorsum of the hand. We mentioned about this. And the deep branch is the muscular branch or the motor branch. So deep branch, it enters the supinator muscle here. Here, this is the deep branch. It enters the supinator muscle. It supplies it. Now, okay, before that, now this one. Now the radial nerve, it it supplies here. It supplies the extensor carpi radialis longus here. Extensor carpi radialis longus before it divides into deep and superficial branches. Okay. Extensor carpi radialis longus is supplied before it divides into superficial and deep branches. Okay. Then the deep branch, when it is given off, supplies the supinator, and before that it supplies the extensor carpi radialis brevis. Then it supplies the supinator. Then the nerve leaves the supinator as the posterior interosseous nerve of the forearm, posterior interosseous nerve. Okay. Now, for our purposes, we don't separate this. We just take deep branch of the radial nerve similar to posterior interosseous nerve. So whether you call it deep branch of the radial nerve or posterior interosseous nerve, we take it as the same nerve because it doesn't make much difference. But the important point is that the extensor carpi radialis longus is supplied by the main trunk of the radial nerve, not the deep branch or the posterior interosseous branch. Okay. Therefore, when you damage the deep branch of the radial nerve or posterior interosseous nerve, extensor carpi radialis longus, it should be longus, is not paralyzed. Therefore, there will not be wrist drop. For you to get wrist drop, you have to have a radial nerve damage. If it's deep branch of the radial nerve damage, no wrist drop. Wrist extension could be weak, but it's not dropped. Okay. So remember this point because of this reason. Okay. Okay. So this is the point I mentioned actually. It comes later. So then this posterior interosseous nerve then supplies all the extensor muscles except these few muscles that were supplied earlier. So extensor digitorum, extensor digiti minimi, all then abductor pollicis longus, extensor pollicis longus, and brevis. All these muscles are supplied by the posterior interosseous nerve. Uh, if the posterior interosseous nerve is damaged, one simple way to look for it, if the posterior interosseous nerve is damaged, is asking the patient to extend the metacarpophalangeal joints. They cannot extend the metacarpophalangeal joints. Okay, because the posterior interosseous nerve is unique for that. So if the radial nerve is damaged, definitely that will be gone. But this is specific for posterior interosseous nerve damage. Okay, median nerve, again, you have the same 5 segments, okay, C5 to T1, no branches in the arm or axilla. Okay, so this brachial artery branch is a vascular branch, okay, no sensory or motor branches. Then, okay, then in the forearm, so in the arm, no branches. In the forearm, the main trunk of the nerve, it supplies, this pronator teres. If you put your 5 fingers here and, you describe the muscles in the forearm, they are supplied by the main trunk of the median nerve. Then it gives a branch which is called the anterior interosseous nerve. It's parallel to, posterior interosseous nerve given by the radial artery. Anterior interosseous nerve, it lies immediately in front of the interosseous membrane and supplies the 3 deep muscles. Okay. So the 3 deep muscles are the flexor pollicis longus, flexor digitorum, um, uh, flexor digitorum, and the flexor digitorum profundus and the pronator quadratus. Okay. Flexor digitorum profundus and the pronator quadratus, and the median nerve supplies the lateral half of it. Okay. The medial half is by the ulnar nerve. So remember this point, if an MCQ says anterior interosseous nerve supplies the flexor pollicis longus, it's true. It supplies the flexor digitorum profundus, true. Pronator quadratus, it's true. Okay, it's not the main trunk, but the anterior interosseous branch. Then the other important thing is the palmar cutaneous branch of the median nerve, which is given off just proximal to the carpal tunnel, and therefore it is paired in carpal tunnel syndrome. Okay, so the thenar muscles, the first 2 lumbricals, and the cutaneous digital branches to the fingers, lateral 3.5 fingers, they are all supplied by the median nerve, which passes through the carpal tunnel. So in carpal tunnel syndrome, these structures can get affected, sparing the skin over the thenar eminence because of the palmar cutaneous branch. Okay. So ulnar nerve, on the other hand, so now Richard Snell, he gives only C8 and T1. C8 and T1. Now, for instance, if you get an MCQ where, the segments of ulnar nerve is checked, so be intelligent, because depending on, the source from which the MCQ is done, you can have C8 and T1 only, or C7, C8, T1. So be careful. It should not come in a question, but sometimes it happens. Different books give different opinion. Now the point here is C7 could be given to ulnar nerve by the lateral cord. Okay, so there can be a connection. So anyway, leave it behind. So C7, C8, T1. Again, no branches in the axilla or arm. Okay, except for small branch to the elbow joint here. So the main branches are given in the forearm and hand. Now, it is in the forearm, it supplies the flexor carpi ulnaris and the medial half of flexor digitorum profundus. Okay. Then it in the hand, so it gives, say, it gives posterior cutaneous branch which supplies the medial aspect of the dorsum of the hand. Okay. And the palmar cutaneous branch will supply the medial aspect of the palm, and the digital branches will supply the medial 1.5 finger. That's a different issue. Then the hypothenar muscles are supplied, and more importantly, all the interossei, okay, third and fourth lumbricals, and the adductor pollicis are supplied by the ulnar nerve. Okay, supplied by the ulnar nerve. So you have this deep branch of the ulnar nerve and the superficial branch. That's a different issue. Now, even though usually we say it ends by supplying the adductor pollicis, but it can enter the thenar eminence here, and it can supply some of these thenar muscles, especially you have flexor pollicis brevis, and you have opponens pollicis. They can, one or two of them can be supplied by branches of the ulnar nerve after the ulnar nerve supplies the adductor pollicis. But usually abductor pollicis brevis is not supplied by ulnar nerve. It says it is the median nerve that is supplied. So in carpal tunnel syndrome, sometimes the other two muscles are not wasted, but you can have only the abductor pollicis brevis getting wasted. Okay. If the ulnar nerve comes in, and if there's a overlap of nerve supply. Okay. Okay. So this is it. So if you have it.